So we would like to get started. I think we're on time for reconvening the committee, and we're all here, so we can reconvene the committee. And I just wanted to announce that we are making an adjustment to the agenda, so those of you in the room and those of you online, we've asked the frequency of eating subgroup, Dr. Heimsfeld, to add on to the agenda. So he will give his presentation after the Beverages and Added Sugars Subcommittee. So we're moving that from tomorrow to this afternoon. And then the rest of the agenda for tomorrow will be as shown. We'll start with the, after opening remarks, we'll start with the B through 24 subcommittee report. So with that, we can turn to the beverages and added sugars. And Beth, Dr. Meyer-Davis.
All right, welcome back, everyone. So first, the committee is shown here, and I want to thank everybody for their engagement. And also, I noticed that the Nesser team is not listed here. I think they're at the last slide, but they are fabulous, and I appreciate a tremendous amount of hard work for this effort. So this is Beverages and Added Sugars Subcommittee. And is there a clicker to advance the next slide? I just realized I was about to advance the slide and I couldn't do it.
We'll make sure that we had it in our possession.
Okay, great. Thank you, Barbara. All right. So we're going to go over the status of these various questions. So we're in the process of developing and implementing various of these questions. There are quite a few. So in terms of developing the plan, working on added sugars with the outcomes of risk for cardiovascular disease, risk of type 2 diabetes, and then growth, size, body composition, and risk of overweight and obesity. We're looking also at added sugars during pregnancy in relation to gestational weight gain, and added sugars during lactation and postpartum weight loss. And so there's some asterisks there to indicate some protocols that will focus a little bit more on today. Then in terms of implementing the plan, there's work ongoing with beverage consumption and growth, size, body composition, and risk of overweight and obesity, beverage consumption during pregnancy and birth weight standardized for gestational age and sex, as well as the outcome of gestational weight gain. And then the last here is beverage consumption during lactation and postpartum weight loss. Still to come, we have some work that we'll present preliminarily on the question set related to alcohol consumption with these outcomes that you see listed here: all-cause mortality, certain types of cancer, risk of cardiovascular disease, neurocognitive health, as well as growth, size, body composition, and risk of overweight and obesity, including alcohol consumed during lactation and postpartum weight loss. We will also look at alcohol consumption during lactation with respect to infant developmental outcomes, including neurocognitive development, as well as the outcome of human milk composition and quality. Okay, so now focusing on a question of non-alcoholic beverage consumption. What is the relationship between beverage consumption during lactation and human milk composition and quantity? And so we're going over the approach to this question, and some of what we'll go over applies to other questions related to beverage consumption. So this is a sort of a chart that allows you to see how we're categorizing beverages so that we can work through this systematically. There are categories related to milk, subcategories of dairy milk, flavored milk, dairy drinks, and substitutes. And then on the far right, water, plain water, flavored or enhanced water as subcategories. And then the rest of the non-alcoholic beverages you see in the middle in these categories of 100% juice, diet beverages, calorically sweetened beverages, nutritional beverages, and coffee and tea. So this is the way that beverages are being sort of categorized, and that applies to other beverage questions, not just the one that we're talking about at the moment. So here are some key definitions and populations for beverages during lactation with respect to human milk composition and quantity. So with regard to beverage pattern, we're thinking about quantities, proportions, variety, or combinations of different beverages in diets. And we'll also consider studies that examine specific beverages or beverage groups. And in terms of population of interest for this question, lactating women who are exclusively or predominantly breastfeeding. And here's some definitions for a couple of those terms. Exclusive breastfeeding, and these are based on World Health Organization from 2001, in which exclusive breastfeeding is defined as infant receiving no other food or drink, not even water, except for breast milk, which can include milk expressed or from a wet nurse. Infants may receive oral rehydration, solution drops, or syrups. And then predominant breastfeeding is breast milk, again, including milk expressed or from a wet nurse. Breast milk that's the infant's predominant source of nourishment. And infants in this case may receive liquids including water or water-based drinks or fruit juices, ritual fluids, or oral rehydration solution drops or syrups. But again, this is where breast milk is the predominant source of nourishment. In terms of inclusion and exclusion criteria for this question, we're using the standard criteria that we've already heard about earlier this morning with regard to publication status, the language, country, health status of participants. But particular to this question, we are allowing case control and cross-sectional studies just because of what we know to be the nature of this literature and what could well be valid study designs for this question. These are inclusion and exclusion criteria. In terms of the study participants, this is women during lactation. For the question about milk composition and in terms of quantity, this would be including exclusively or predominantly breastfeeding women. I do want to note, in terms of exclusion criteria, we are excluding studies that exclusively enroll multiple gestation pregnancies or exclusively present combined analyses of singleton and multiple gestations or human milk from third parties, banked or donor milk. And then in terms of health status of study participants, we will include studies that enroll mothers who are healthy and or at risk for chronic disease, those that enroll some mothers diagnosed with disease, studies that enroll some mothers who were severely undernourished prior to pregnancy, and we will also include studies that enroll some or all mothers classified as underweight or obese prior to pregnancy. The studies that are excluded are those in which the study participants exclusively include mothers who gave birth to preterm infants, or studies that exclusively enroll mothers diagnosed with a particular disease, including severe undernutrition, or exclusively enroll mothers who are hospitalized with an illness or injury, and those obviously have to do with generalizability. All right, and this is the analytic framework then for this question of beverages during lactation and human milk composition and quality. You can see the intervention or exposure, and that list of beverages reflects the chart that I showed a few minutes ago and how we're sort of thinking about different beverages. And then the comparator would be different amounts of those beverages or the physical form in which those foods might be consumed. And then you see it below there, the population for the human milk composition question and the human milk quantity, and those are consistent with what I just showed a minute ago. And then in terms of the outcomes, for the human milk composition, this would be milk collected greater than or equal to 14 days postpartum, in which we will look at macronutrients, particularly fatty acids and total protein, water-soluble vitamins, fat-soluble vitamins, selected minerals, bioactive proteins, and then in terms of human milk quantity, we'll be looking at that assessed in milk collected again at least 2 weeks postpartum. And then in terms of human milk composition, women during lactation, this is well, I don't need to repeat that. We already talked about the population, both for milk composition and also milk quantity. We then have key confounders that were identified that we will be paying attention to with regard to risk for bias. You can see those here: maternal age, race, ethnicity, socioeconomic status, anthropometric measurements, gestational age, smoking, supplement intake during lactation, and then a number of other factors that we will consider as well. Okay. With regard to added sugars, here are some of those questions. What is the relationship between added sugar consumption and risk for cardiovascular disease, risk for type 2 diabetes, growth, size, body composition, and risk of overweight or obesity? So we're presenting these in a sort of coordinated fashion because a lot of the analytic framework is common for these outcomes. And then moving to the question of what is the relationship between added sugars consumption during pregnancy and gestational weight gain, and then the relationship between added sugars consumption during lactation and postpartum weight loss. So it's important to first think about what are we considering to be added sugars, and this is the FDA definition from when? From 2016. You see that here: sugars that are either added during the processing of foods or are packaged, such as, for example, a bag of sugar. And added sugars include, a variety of sugars, sugars from syrups and honey, sugars from concentrated fruit or vegetable juices that are in excess of what would be expected from the same volume of a 100% of a fruit or vegetable of the same type. We will consider studies that use a somewhat different definition of added sugars. Not everyone would use the same definition, but this FDA 2016 definition is really what we're talking about. And then there's a variety of examples here that would be part of that definition. Additionally, in terms of key definitions for this set of questions, prediabetes is defined per the American Diabetes Association. You see that detail here. And similarly, type 2 diabetes defined according to the current ADA definition. All right, in terms of inclusion and exclusion criteria for these added sugars questions, and again, we're talking about added sugars and these outcomes: CVD, type 2 diabetes, growth size, body composition, and risk of overweight and obesity. We are using the standard criteria that we've talked about earlier today. And in terms of inclusion and exclusion criteria, with regard to study duration, and this is for the question of relationship between added sugars and growth, size, body composition, and risk of overweight or obesity. We do have a criteria with regard to study duration that we wanted to point out here, which is a minimum duration for experimental studies of at least 8 weeks. There's not a duration cutoff for observational studies, but when talking about an interventional study, an experiment, then that minimum duration is 8 weeks. These are inclusion and exclusion criteria for study participants. For CVD, with regard to age, and you'll see later, their intermediate outcomes that would be relevant here. So for CVD, children aged 2 to 5, 6 to 12, and then for type 2 diabetes, adolescents 13 to 18, and then adults 19 and older, including older adults age 65 and older. And then for growth, size, body composition, and overweight, there's a note here that says this is still in discussion between the Beverages and Added Sugars Committee, our committee, and Birth to 24. So I have late-breaking news. We had a lunch meeting just a minute ago, and this is probably the best time to mention this. So we're coordinating with regard to the analytic framework so that the work is coherent, consistent between the two subcommittees, And then the Nesser team will be, screening, doing the search, screening the literature accordingly. But it is the birth to 24-month subcommittee that will really be doing, the lion's share, really focusing on that synthesis piece for the question of added sugars for this age group, because, they obviously will have a broader context with regard to complementary feeding, et cetera. So that's the update to the slide. And Kay will tell me if I missed that. She looks happy. Okay, we're good. Yep. All right. So then continuing inclusion and exclusion criteria with regard to health status. So for cardiovascular disease and type 2 diabetes, we'll look at studies that enroll participants who are healthy and/or at risk for chronic disease, including those with obesity. Studies can enroll some participants diagnosed with the disease. And again, for CVD and type 2 diabetes, studies can enroll some participants with endpoint outcomes, but we will exclude studies that exclusively enroll participants diagnosed with the disease or hospitalized with an illness or injury. In other words, we don't want to be focusing on treatment effects here. And for CVD only, we will include studies that exclusively enroll participants with high blood pressure, high cholesterol, and are evaluating a CVD endpoint. In other words, studies that aim to prevent cardiovascular disease in individuals who are already at high risk as a consequence of those diagnoses. So those will be included. In terms of gross size, body composition, overweight, and obesity, we will include studies that enroll participants who are healthy or at risk for chronic disease, studies that enroll some participants with the disease, and studies that enroll some participants who are already classified as underweight, stunted, wasted, or obese. But we will exclude studies that enroll individuals diagnosed with disease or hospitalized with an illness or injury, or studies that exclusively enroll participants classified as obese for the same reason that we're not focusing on treatment effects. Okay, so here's the analytic framework for the outcome of cardiovascular disease. The exposure is consumption of added sugars from foods and beverages. And again, an update, this is for ages 2+ through older adults. And the comparator would be different levels of added sugars consumed, including no consumption or consumption of various low-calorie sweeteners. If you look over to the right, these are the health outcomes: cardiovascular disease, as listed there, stroke, venous thrombosis, cardiovascular disease-related mortality. There are a number of intermediate outcomes as well that can be considered with respect to the added sugars exposure, and those include total cholesterol, LDL, HDL, including total cholesterol to LDL ratios, LDL to HDL ratios, triglycerides, and blood pressure. The key confounders are shown here: age, sex, race, ethnicity, SES, alcohol intake for adults, physical activity, anthropometric measures, smoking, and naturally occurring sugar intake, and then a variety of other factors to be considered. And I'll note here, I can't remember if it's come up earlier today, we are considering total energy intake in these papers. We decided not to include that as a key confounder, though, because depending on the design of the study, it may be that total energy intake is appropriately considered, but not as a confounder per se, again, depending on the design of the study. So total energy intake will be considered one way or the other. Okay. Let's see. This is the analytic framework for type 2 diabetes. Relationship between added sugars and risk of type 2 diabetes. And again, the intervention or exposure is the same as the previous slide, the comparator the same as the previous slide. The outcome is type 2 diabetes. And again, there are some intermediate outcomes that can be considered: hemoglobin A1C, when it's not defining the outcome of type 2 diabetes, glucose, insulin, and prediabetes. And again, you'll see key confounders that are similar, and other factors to be considered that are similar as well, with some additions that are specific to this particular outcome, including acanthosis. And then moving to the analytic framework, this is for relationship between added sugars and growth size, body composition, and risk of overweight and obesity, in which the intervention or exposure is the same and the comparator is the same. And the outcomes here include weight or weight for age. Well, that was there when we still weren't sure what to do with birth to 24. Now we figured that out. Height, BMI, BMI Z-score, various circumferences, body composition and distribution, percent fat mass, percent fat-free mass as may be available from the different studies. Also incidence and prevalence of underweight, stunting, healthy weight, overweight, obesity, et cetera. And then the key confounders are listed here. Again, similar to what was seen previously, and then other factors to be considered also similar to what we saw previously. One thing that I do want to note here that I didn't mention earlier is that one of those factors to be considered would be supplements and various medications that we would need to consider. All right, so this is inclusion and exclusion criteria for the added sugars consumption question. This is what is the relationship between added sugars during pregnancy and gestational weight gain, and what is the relationship between added sugars during lactation and postpartum weight loss, in which we will again use the standard criteria, the standard Nesser criteria for study design, publication status, language, country, and health status of participants. And these are inclusion and exclusion criteria for these questions. Again, we will use this minimum duration of 8 weeks for experimental studies, same as I mentioned previously. And these are inclusion and exclusion criteria. We will include females who are pregnant, females capable of becoming pregnant, and again, excluding hospitalized patients, studies that exclusively enroll subjects based on pregnancies conceived using assisted reproductive technologies, studies that exclusively enroll multiple gestation pregnancies, and studies that enroll both singleton and multiple pregnancies but do not account for singleton versus multiple gestation in the design or analysis and only present aggregate findings. So those are excluded. For postpartum weight loss, we will include postpartum women who are lactating, again, excluding hospitalized patients and excluding studies that enroll both lactating and non-lactating lactating mothers, but only present data in combination for those lactating and non-lactating mothers. Right, and this is inclusion and exclusion criteria in terms of the health status of the study participants for gestational weight gain and postpartum weight loss. So studies that enroll mothers who are healthy or at risk for chronic disease, those that enroll some mothers with diagnosed disease, studies that enroll some mothers who were severely undernourished prior to pregnancy, and studies that enroll some or all mothers classified as underweight or obese, but we will exclude from this review studies that only enroll mothers who gave birth to preterm infants and those that exclusively enroll individuals diagnosed with a particular relevant disease, including severe undernutrition or those hospitalized with an illness or injury. And this is the analytic framework for the outcome of gestational weight gain. The exposure is the same, the comparator is the same as mentioned previously. The population criteria are summarized there on the box on the left. And the outcome here is gestational weight gain as change in maternal body weight from baseline sometime before or during pregnancy as is available to a later time point during pregnancy and or right before delivery. And then weight gain in relationship to weight gain recommendations based on pre-pregnancy BMI. And then you see here key confounders and other factors to be considered that are specific to this question, very similar to what we've seen previously, including considering first trimester weight gain. Okay, and then this is for postpartum weight loss. Same intervention or exposure, same comparator, and then the outcome is change from weight, or change in weight from baseline postpartum to a later time point in the postpartum period, and postpartum weight retention if gestational weight gain is controlled for. And the population is shown there. And the key confounders and other factors to be considered are similar to what we showed previously. So this is an example of work underway and progress. This is for beverages during pregnancy with respect to birth weight. And it's just kind of interesting to see the search began with an initial identification of 7,646. Some duplicates were identified, which cut this down to 4,447. Screening process occurred, and then articles ultimately included numbered 22. And so those are the studies that are currently under review at this point in time. So we don't have results from that effort. They're still under review. So work underway. I mentioned at the beginning of this section that we've been active with regard to the alcohol questions. So the complete protocol is not available just yet, but will be presented at the next public meeting. But just to give you an idea of where we are with this, the exposure with regard to alcohol intake is level of consumption of alcoholic beverages, as well as the per occasion consumption of alcoholic beverages, such as number of drinks per day or drinks per drinking occasion. And when a study has available the distinction between beer, wine, and liquor, that will be considered as well. The comparator will be different levels of alcohol consumption for the population of adults age 21 and older. And we're in the process of considering what exactly we will include with regard to the key confounders and the other factors that will need to be considered in this particular literature. So next up, obviously, we will finalize the alcohol protocols and discuss those more completely at the next public meeting. We'll finish the screening questions with complete search results, looking at the 4 beverage questions and the 5 added sugar questions, and synthesize findings. Hopefully we'll have a good amount of that done to present at the next public meeting, and continue with cross-cutting discussions with especially the analysis group and B24 subcommittee. I think that's it, and these are our subcommittee members, and there we have the support staff named. So thank you very much, and this is open for questions.
Kay Dewey, I just have a quick question about what you said about treating total energy intake as another factor to be considered. You said that you would be taking into account if it was handled appropriately, and I'm just wondering quite what that means, because one possibility is that it could be a mediator, which is a very different interpretation of what's going on than a confounder or something else. So I wonder if you'd like to speak to that.
So that's a great example of a situation in which total energy might not be adjusted for, as is common, especially in the epidemiological literature, as a confounder, but when in fact total energy may not be a confounder, it might be a mediator. And if a mediator, that's a different question altogether. So that was actually a wonderful example of what we meant by not including total energy as a confounder, but rather as another factor to be considered. Confounding is not the only role, that total energy plays in any given analysis. depending on the research question. So that was a great example, so thank you for that.
Other questions or comments? Great, Jamie.
Jamie Ard, I had a question about the gestational weight gain, or actually more specifically the postpartum weight retention studies. So is it the intent to exclude studies that are intervention studies in that particular scenario? Because those are kind of a little tricky. If based on the inclusion-exclusion criteria, right, you could get randomized controlled trials that would assign women to an intervention for weight reduction compared to one that would be a control. But that's not necessarily a disease per se, right? And I don't know if that would be the intent. Would that be the same intent in terms of what we're trying to get at with that particular question?
Right, so if there's a study that's an RCT looking at approaches to, improve that trajectory of weight following delivery, those would be included. And unless I missed something in the analytic framework that perhaps needs to be clarified or corrected, we would not want to exclude those kinds of studies. Presumably, the women would be, generally healthy women who didn't all have, say, a particular diagnosis. So for example, if all the women in the study had a diagnosis of gestational diabetes, that would be an example of one that would be excluded because it would be more focused on treatment, essentially, or prevention of development of diabetes following delivery, all in women in gestational diabetes, and that's a rather different question. So with that type of exception, otherwise the kind of study that you're describing in RCT where the outcome is, optimal postpartum weight loss, those would be included. And anyone can correct me, and maybe we need to look again at the analytic framework and make sure that that's clear.
Even if a calorie restriction were prescribed?
I don't see any reason that that would be excluded. Yeah.
I think the issue is whether there is control for the beverage. The question is, does drinking something during that period of time have some differential effect? So as long as that's the independent variable, it would stay in. If it wasn't controlled adequately, then it would be confounded for our interpretation.
Right, and thanks for that clarification, because that was my assumption that I didn't articulate, so thank you for that.
I think it is worthwhile to observe that this is the first time there have been beverage questions, so it has been challenging for the subcommittee to develop the protocols and keep the focus on the beverage aspect of it. So I don't know if there's anything more you want to add, but it is something unique for this evaluation.
Yeah, I mean, it might be good to just note in terms of the comparator, this is maybe where this comes in with beverage as a new sort of component of this process in general. So the comparator has to do with the amount of intake of whatever beverage is being looked at in a given study, or the comparator could be with respect to the physical form, whether something is in the physical form of a beverage versus a solid physical form. So that's how we're framing the comparator as we're taking this first look at beverages explicitly, as part of the dietary guidelines process.
In one of the analytical frameworks, one of the key confounders was other supplemental sugar. And maybe I got that.
Naturally occurring.
Oh, was it naturally occurring sugar or something along those lines? And I was just curious how widely that is available in these studies that you're reviewing. Maybe and the reason I was thinking about that was that it was a key confounder, and since, if, a study gets lower rank if it's missing a key confounder. And so I just was wondering how powerful this was, that it was a key confounder.
So, yeah, this is a rather difficult one because, it is a question, how many studies really adjust for this? And I can just think of a couple studies just that are going through my mind with respect to, say, fructose, whether it's, added, as in, high fructose corn syrup or something, versus naturally occurring fructose. I mean, so it's tricky, and it'll be a little tricky in the literature, and so that's something that will be looked at to really see, what was actually measured, how the exposure was very specifically defined, and, what analyses were done to try to distinguish between what we're interested in, which is added sugars, versus naturally occurring sugars. So, we're just going to have to see, what is possible to discern for different papers, and literature where we can't sort that out, obviously will not be given the same, level of validity.
Just to sort of add to that, one of the issues that we struggled with is the concept of added sugar versus just the physiology of taking in sugar, whether it's added or inherent. And so we thought it was important that we capture totality of sugar intake if we want to be able to isolate the added sugar intake. And so it really is pretty key to get that information.
I got it. Sorry. It finally worked. Any other questions or comments for those of you strong enough to push that button?